We'll be talking about the outcomes of laparoscopic liver resection for hepatocellular carcinoma and metastatic colorectal cancer. Thank you. In 2009, a world review was published, and in that time, there were about 127 papers in PubMed on laparoscopic liver resection, representing approximately 3,000 patients. 50% of the resections in the world literature at that time were for malignancy, and the top cancers were hepatocellular carcinoma at 52%, and about a third for metastatic colorectal cancer. The outcomes were across the 127 papers were outstanding, with less than 1/2 of 1% mortality. A more recent review by Ruben Soria showed now, published 2 years ago, Annals of Surgery 2016, up to 10,000 cases of laparoscopic liver resection, and the malignancy percentage has increased from 9 to 16, so in about 7 years it's gone up to 2/3 of the cases reported are now for cancer, 1/3 for benign, about 180 series. Mortality remains extremely low at 0.4%. And in a subset meta-analysis of 3,000 of these 9,000 cases, where there was excellent case matching on lap to open, the lap liver resection had less complications, less blood loss, less transfusions, shorter length of stay versus open liver resection. So that's the benefits of, in this second world review of laparoscopic liver resection. Those short-term benefits were confirmed in this nice NISQIP study published in JOGS in 2016, where it was a propensity score match of 609 lap liver resection, LLR, to open liver resection, all in the year 2014. So they were contemporaneous matching from the NISQIP database in year 2014. And the conclusions are shown here. The white bar columns are the lap liver, the black are the open. The lap liver cases had less transfusions, less morbidity, less surgical site infection, less post-op pulmonary embolus, less post-hepatectomy liver failure, and decreased bile leak compared to the open. So those two are some summary of the short-term benefits. The rest of the talk will focus on what are the long-term cancer outcomes with laparoscopic liver resection, and I'll focus only on the two cancer diseases, HCC and metastatic colorectal cancer. We'll start with colorectal mets. Here's a slide of 18 studies starting in 2009. This was a Pittsburgh multi-center series, and up to 2016. This is from the Southampton group, where 5-year survival, these are the number of patients in each of the series, these are the countries they come from, and they're all 5-year overall survival data in 18 studies range from around 50 to 70%. If we subset out those 18 studies, which of the studies also included case matching on lap to open, those are shown here, 2009 to 2016. And the first column here is the lap number, case match to open. Most of the time they're 1-to-1 matching, but here a study from Louisville was 1-to-4 matching. Here was a study from Japan, 1-to-2 matching. Here about 2-to-1 matching, and here and 1-to-1, all with 5-year overall survivals. These are the percentage 5-year survivals, again around 50 to 60% 5-year survival. Not a single, NS means not significant, so there wasn't a single study showing inferior or worse results in the lap group compared to open. And the conclusions from looking at these 12 studies are that lap liver resection has comparable 5-year overall survival versus open liver resection for metastatic colorectal cancer. Now, the true critics might say, well, these, no matter how much you case match or propensity match, there's going to be some intrinsic bias, so we're going to come to a randomized trial in a minute. But before we get to that, something that was of great interest when I looked at these studies and others was, well, which patients with colorectal mets are really good candidates for lap liver according to the literature? Because we've all operated on a patient with 1 met, but we've also operated on patients with 5 or 6 mets, as we know, because the paradigm has shifted, and it's not number of metastases. It used to be 4 or less 20 years ago, and now it's really parenchymal preserving, and do we have enough future liver remnant? So we looked at a meta-analysis published in Surgery 4 years ago in 2014 of extremely rigorous case matching. There are 8 studies that fulfilled the criteria and had at least 10 patients per per group. And in these studies, the median number of METs in the lap group was 1.4, and the open group 1.5, which basically meant half the patients had 1 MET and half had 2 METs, to give 1.5 as the average. And 5-year overall and disease-free survivals were comparable in this meta-analysis of these 8 studies. So I interpreted this to mean, well, even though we may operate on patients with more, the literature supports laparoscopic resection for colorectal METs with limited number of METs, which typically means 1 or 2 metastases. And that observation was also confirmed in this Japanese multi-center study that Go led the publication. They looked at patients from 2005 to 10, so modern era, and it was a propensity match 1-2, 171 lap against 342 open. And the majority, 75%, 3/4 had 1 metastasis, and the other quarter had limited 2 to 4 metastasis. So the same type of conclusion as the meta-analysis, it's really the data supports limited. It doesn't mean that someone may not, if you have 5 METs in a right lobe, you could do a laparoscopic right lobectomy for 5 colorectal METs, but the literature really supports limited colorectal METs. And again, in this study, no difference in the R0 resection rate. Disease-free survival was 53 and 51, and 5-year overall survival was outstanding at 70 and 68 in the lap versus open group. This is now the Cadillac, if you will, the gold standard is a randomized clinical trial. We're fortunate because it'd be difficult, if not impossible, to do this study in the United States, but because of the way healthcare is socialized in Norway, Bjorn Edwin and the Oslo COMET group took this randomized clinical trial from 2012 to 16, randomized 133 were randomized to lap, 147 to open. The concept was parenchymal sparing. The 2 groups were well matched for number of METs, location, CEA, clinical risk score, and the use of pre-op chemo. There were benefits of less post-op complications in the lap group versus open, statistically significant, and a shorter length of stay. No difference in blood loss, OR time, margins, or total cost. And using the European guidelines, the quality of length and quality of life adjusted years were better in the lap group. So the conclusion of this landmark randomized clinical trial, laparoscopic versus open resection for colorectal METs, shows it's that a positive randomized clinical trial in favor of laparoscopic liver resection for short-term outcomes. We don't have the long-term 5-year cancer data, and we look forward to hearing that perhaps in Tokyo or beyond. We'll conclude with now what are the cancer outcomes for HCC for laparoscopic liver resection. This is a nice study, another Japanese multi-center study, 31 sites in Japan, 1-to-1 propensity match, 387 patients in each group. They were well matched for age, gender, child score, ICGR15 clearance, Hep B, C status, tumor size, number, location, extent of resection. And the conclusions were the lap liver had significantly less blood loss, shorter length of stay, and less post-op morbidity. So similar short-term benefits for colorectal METs, no differences in 1, 3, or 5-year disease-free or overall survival. And here's the Kaplan-Meier survival where the curves are virtually superimposable. Again, a summary of about 18 studies where now 5-year, from 2001 to 2016, case matching. These are the 5-year survivals, 50 to 60% for survival, all reporting 5-year, no difference in any of the survival in any of the laparoscopic cases. So conclusion is that lap liver resection is comparable 5-year overall survival versus open liver resection for HCC. This is a small but interesting second randomized clinical trial, this time for HCC. It was from an Egyptian team. They presented this a year ago at the AHPBA meeting and published it in November 2017 in Journal Laparoscopic Advanced Surgical Techniques. They were pretty selective, so to get entrance in the trial, you had to have a solitary HCC less than 5 centimeters in child's A in peripheral segments, which we know is more appropriate for a cirrhotic. And they were well matched for age, gender, ASA score, BMI, Hep C status. They were all Hep C positive. Tumor location, size was a golf ball, 3.3 centimeters in pre-op AFP. The benefits were the lap group had shorter OR time, shorter length of stay, less narcotic use, which is nice to see pain measurement, and shorter time to regular diet, no difference in blood loss, transfusion rate, R0 complications, and they had short-term follow-up of disease-free survival comparable at 3 years. So this is a positive randomized clinical trial in favor of lap liver resection for HCC. So we've had 2 published clinical trials now randomized. I will conclude by saying lap liver resection has been done in more than 10,000 patients worldwide. There are comparable oncologic outcomes with R0 rate, 5-year disease-free, and overall survival reported for both HCC and limited colorectal metastasis using case control, propensity score matching, or meta-analysis. And we have 2 randomized clinical trials that we await long-term data. The Oslo COMET study showed shorter length of stay and less morbidity, and the Egyptian randomized clinical trial for HCC showed shorter OR time, length of stay, narcotic use, and time to diet with similar short-term 3-year disease-free survival. Thank you.